So since I'm speaking first, I think it is quite important that I highlight a couple of facts about menisci. We know very well that they are very important structures in the knee joint. They serve a lot of biomechanical functions. The most important of them being load transmission, because they transit the load or transmit it from the femur to the tibia. If you do a meniscectomy, then it obviously results in increased peak contact pressures, and again the amount of meniscus removed is, I think, the most important predictor for development of knee osteoarthritis. When you resect meniscal tissue, there's going to be an increased joint stress over a period of time, and this is going to lead to osteoarthritis. Tears can be divided into two types. You have the traumatic tears, which are especially seen in young, athletic, healthy individuals. Often they are associated with ligament tears, usually in a vertical longitudinal pattern, and they are the ones that I feel should be amenable to repair. On the other hand, you have degenerative tears, which are usually seen in slightly older patients. They may happen with trivial trauma, and they usually have a minimal healing capacity, usually the horizontal cleavage or complex patterns, and they may or may not be amenable to repair in my clinical practice. So it's been shown over the last century or last 50 years that the meniscus is capable of healing if there is accessibility to blood supply. And this is probably the most common downloaded slide or picture in the medical literature, wherein Arnoxy showed that the peripheral capillary plexus nourishes the meniscus, and I think any tears in this region are very important. So I think one must exercise a lot of caution while repairing tears. Tears which are especially in zone 1 or some zone 2 are usually amenable. In my clinical practice, repair patterns like the longitudinal vertical or the radial tear are the more important ones that I need to repair. I think we need to also look at the chronicity of repair. If you have chronically torn menisci, they need to come out. Sometimes the menisci may get some additional vascularity from surrounding structures. A certain proportion of these are also amenable for repair. As you can see in this particular video here, we've gone ahead, resected this extra vascularity that has come, and we've been able to repair the whole meniscus with a good outcome. Age is also important when I select my patients. Younger patients will have better outcomes. Knee stability is also a very important aspect, and knee alignment is important when you're doing meniscus repairs, and that also should be considered absolutely properly. And a large proportion of your ACL ruptures will also have a large percentage of tears that one should repair. When you're repairing tears, you must respect all the proper principles. Doing an abnormal or an incorrect meniscal repair will result in failure. And you have a variety of meniscal repair techniques which all of us should be aware of. If you want to undertake a meniscus repair, there's no use of undertaking a meniscus repair if you are not trained properly on the correct surgical technique. So literature does show us that if you do a good meniscus repair, you have a very good chance of survival. As in this excellent paper about a decade ago, it shows that almost about 20% of patients will fail, but in the first 24 months, and probably these were patients that had a poor surgical technique or there were a wrong indication, and once you cross that 24-month period, then there is absolutely no drop off in your meniscus repair survival. Again, if you look at meniscus resection after a repair, that means you've repaired a meniscus and for some reason you need to go and resect. It's been shown again very elegantly that if you go ahead and do a secondary resection, then you resect 84% less meniscus than what you would have done, which is a very important fact, and you have a 50% chance of less chondral lesions, which I think is very important. Another long-term outcome comparing meniscus repair and resection, it's important to note that if you do a meniscus repair, 80% of patients will not have osteoarthritis at long-term follow-up, and 96% will go back to their pre-injury level as against those who've had a partial meniscectomy. So pick your winners. Pick winners which are in the zone 1 and zone 2. Pick winners more on the lateral side than on the medial side, because the medial sided tears are likely to fail slightly more than the lateral sided tear. Pick your winner. A long extended tear does have a poor prognosis, but remember, a long extended meniscectomy will have a poorer prognosis. So I think that's some food for thought. Another meta-analysis shows that repair has better outcomes than meniscectomy in long term, better activity levels, and a meniscus repair has a lower failure rate than meniscectomy. Two tear patterns which I think are very important, where there is no controversy at all, are the ramp lesions as well as the root lesions, which have no option, but if you resect them, then I think you are asking for disaster. If you do a meniscus root resection, then I think you're looking at a comparable result to a total meniscectomy. So to conclude, saving meniscus tissue is of prime importance. It does a lot of protective functions. You need to be technically correct, and I think that's the most important message that I need to tell you. So my esteemed opponent Swapnil, he's a fantastic athletic individual. He's got good strong knees, and Swapnil, I'd like to ask you, if you get a meniscus tear, what should I do? Shall I cut it off or shall I repair it for you? Okay, so thank you very much, colleagues, and I would like to invite all of you to next year's Pune knee course, where meniscus repair would definitely be a hotly discussed topic. Thank you.